What if the ache in your calf when you walk up a flight of stairs isn't just, a sign of getting older? What if it's actually a blaring systemic alarm telling you that you are at an immediate risk of a heart attack?
Yeah, that is exactly the reality for millions of people. Today, we're looking at a disease that operates almost entirely by stealth.
Right. We are deep diving into peripheral artery disease, or PAD. We're going to unpack the pathophysiology of this condition, specifically looking at the mechanics of how narrowed arteries literally starve the limbs of blood.
And we have a really fascinating stack of clinical sources today. We're going to explore how the entire diagnostic field tracks back to a pretty quirky veterinary origin story involving French horses.
Yeah, the history is wild. And we'll look at why a seemingly isolated pain in your leg is actually a siren warning for your heart and your brain. Okay, let's unpack this. What exactly is happening at a cellular level when we talk about PAD?
Well, to really understand PIT, you first have to understand the underlying driver, which is atherosclerosis. Atherosclerosis is basically the buildup of plaque inside the walls of your blood vessels.
And just to clarify, this isn't just a soft glob of fat resting on the surface, right?
No, not at all. That's a
Really?
huge misconception. It's a highly complex, hardened mixture of cholesterol, fatty deposits, cellular waste, fibrous tissue, and calcium. And it actually integrates into the lining of the artery itself.
Oh, wow.
Yeah. So when this plaque builds up inside the arteries outside of your heart and brain, which in the vast majority of clinical cases means the arterial network supplying your legs, that is the literal definition of peripheral artery disease.
So the tube is just getting physically blocked.
Exactly. As this plaque grows and hardens, the internal channel of the artery, the lumen, gets narrower and narrower, and eventually the blood flow drops below what the tissue actually needs to survive.
So the overarching theme here really is starvation. The muscle tissue in the legs is quite literally starving for oxygen and nutrients.
Precisely. And this starvation becomes acutely obvious when the demand for oxygen spikes. At its mechanical core, PED is a massive supply and demand mismatch.
Right.
Think about the physiology of your muscle tissue. When
Yeah.
you're just, sitting on the couch reading a book, the oxygen demand in your leg muscles is pretty modest.
Sure.
But a healthy artery has this incredible dynamic ability to dilate, to widen its internal diameter, and multiply its blood flow several-fold the exact moment you stand up and start walking.
I think about it like this. Think of a healthy artery like a dynamic highway. At 2 a.m., which is you resting on the couch, it's a 2-lane road and traffic flows perfectly fine.
Right.
But at 5 p.m. during rush hour, which is you deciding to jog up a steep flight of stairs, that healthy highway can magically expand to 4 or 6 lanes to handle the massive surge in traffic. But a diseased artery is stuck as a fixed, rigid 2-lane road. So at 5 p.m., when the demand spikes, you get a massive, painful metabolic traffic jam.
That is exactly what happens. A diseased, plaque-filled artery just cannot dilate past that hard, calcified blockage to meet the new metabolic demand of the exercising muscle.
It's basically a rigid pipe at that point.
Yeah. It might let just enough blood trickle through to keep your leg tissue alive while you're resting, which is why millions of people with significant vascular disease feel absolutely nothing when they are sitting still.
But once they move,
Right, once they move, that metabolic traffic jam produces a very specific clinical signature called intermittent claudication.
which translates to ischemic pain, basically pain from a lack of oxygen that appears predictably. You walk 2 blocks, your calf cramps, you stop, and the pain completely vanishes within minutes. Walk, hurt, stop, relief.
Exactly.
But this disease isn't static, right? The highway continues to narrow as the years go by.
It does. Over time, as that plaque burden increases, the narrowing becomes critical. Now, the body does try to fight back. It attempts to grow small, natural bypass channels around the main blockage.
It's a collateral vessels.
Yes, collateral vessels. But eventually, the disease outpaces the body's ability to compensate. When the blood flow becomes insufficient even to maintain resting tissue, you cross a really dangerous threshold into what's known as rest pain.
And that's usually in the foot, right?
Yes, usually in the foot or the toes. And it is notoriously agonizing at night.
Because in gravity, when you're lying completely flat in bed, gravity is no longer helping to pull the arterial blood down into your feet.
Exactly. Patients often learn to dangle their foot off the side of the bed in the middle of the night just to get gravity to push enough blood down there to stop the throbbing.
This sounds awful.
It is. Dangling the limb is a major clinical red flag, and if the starvation continues beyond that point, we reach the severe end of the disease spectrum, which is actual tissue death.
Right.
The field now refers to this as chronic limb-threatening ischemia, or CLTI. This is the stage where you see non-healing ulcers on the feet, gangrene, and a very real imminent risk of major amputation.
Okay, so we've been talking a lot about the calf and the foot, but what if that traffic jam happens much higher up, like at the very main junction where the aorta splits to feed the lower half of the body?
That's an excellent distinction, and it leads to a very specific clinical presentation known as Leriche syndrome.
Leriche syndrome.
Right. If the PAD blockage occurs high up in the aortoiliac arteries, which are the primary trunks branching off the abdominal aorta, the starvation affects the entire pelvic and leg region.
So the symptom profile completely changes based on the geography of the blockage.
Exactly. With Leriche syndrome, patients experience a triad of symptoms. They get claudication that affects the buttocks and thighs rather than just the calves. They have an absolute absence of detectable pulses in the groin.
Wow, no pulse at all.
Right. And the third symptom is erectile dysfunction because the entire regional arterial network is starved of adequate blood pressure. It perfectly illustrates how structurally dependent the entire lower half of the body is on those central vascular highways.
So mapping this out, the mechanics of the pain seem incredibly straightforward. You demand oxygen, the artery can't deliver it, it hurts. You'd assume diagnosing this is the easiest thing in the world. But our sources show the epidemiological data tells a completely different story.
Oh, completely.
It reveals this massive iceberg where these classic textbook symptoms are actually the exception, not the rule.
Yeah, this is arguably the most dangerous misconception regarding PAD. There was a landmark 2013 global analysis published in The Lancet, and it estimated that over 200 million people worldwide were living with peripheral artery disease.
200 million.
Yes. But here is the terrifying part. When researchers proactively screened people in the community, they found that only about a quarter to a third of people with objective, measurable arterial blockages actually reported that classic walk and rest claudication pain.
Wait, meaning tens of millions of people are walking around with starving limbs and don't fit the textbook diagnostic profile at all? How do they just not feel their muscles suffocating?
Well, for many, they've simply unconsciously modified their lifestyle to avoid the pain threshold. They just slow their walking pace, they take the elevator instead of the stairs, they stop gardening, and they attribute the slowdown to simply, getting older.
Right, they just adapt to it without realizing it.
Exactly. And others experience atypical pain, like a heaviness or weakness in the leg that doesn't fit the precise walk and rest pattern, so it doesn't immediately trigger a physician to think vascular disease.
Because symptom reporting was so unreliable, the medical field realized they needed a hard, objective hemodynamic number to define the disease.
Yes, exactly.
Enter the ankle brachial index, or the ADI. This is the absolute diagnostic anchor for vascular medicine. And it's actually a beautifully simple piece of physics. You take a standard blood pressure reading at the patient's ankle, then you take a blood pressure reading at their arm, and you just divide the ankle pressure by the arm pressure. In a completely healthy person, that ratio should be about 1.0, maybe even a little higher, because blood pressure shouldn't drop significantly as it travels down a wide-open arterial tube to your foot.
That's right. The physics dictate that pressure should be maintained. But if there is a significant atherosclerotic plaque blockage anywhere along the leg, it acts like a kink in a hose. It chokes the pressure downstream.
So the ankle pressure drops.
Exactly. So if your ankle pressure is significantly lower than your arm pressure, specifically an ABI ratio of 0.90 or lower, that is the definitive clinical diagnosis of PADs. It is incredibly accurate for confirming that a blockage exists.
But wait, so a higher, seemingly reassuring score on the gold standard test actually means your arteries might be diseased in a completely different, calcified way. The test actively lies to us.
Yes. This is a critical divergence in how the disease manifests. And it happens in a specific group of patients, mainly people with diabetes or advanced chronic kidney disease.
Right.
In those patients, their arteries undergo a distinct process called Munkeberg sclerosis. In classic atherosclerosis, the plaque builds up inside the lumen, the hollow tube of the artery. But in Munkeberg sclerosis, the middle muscular layer of the artery wall itself becomes heavily calcified.
I really want to dig into the why here. Why does having diabetes or kidney disease cause the actual muscle of the artery to basically turn to stone?
What's fascinating here is that it comes down to a fundamental disruption in calcium metabolism. When you have chronic elevated blood sugar from diabetes or uremia, which is a buildup of toxins in the blood because the kidneys are failing, it triggers this crazy cascade of cellular confusion.
Cellular confusion?
Yeah. Smooth muscle cells in the artery wall actually undergo a phenotypic switch. They begin to mimic osteoblasts, which are bone-forming cells.
Wait, really? They literally forget they are blood vessels and start trying to build bone in the leg.
Essentially, yes.
Uh-huh.
They actively deposit calcium phosphate into the arterial wall. The artery transforms from a flexible muscular tube into a rigid structure.
So let's look at what that does to the gold standard test. Imagine trying to squeeze a rubber garden hose shut by wrapping a blood pressure cuff around it and inflating it. Very easy.
Right.
Now imagine trying to squeeze a rigid PVC pipe shut with that exact same blood pressure cuff. You can inflate the cup until the nylon bursts, but the PVC pipe is not going to compress. So the machine registers an artificially massive pressure reading, an ABI of maybe 1.40 or higher.
That analogy perfectly captures the physics of the failure. The ABI test relies entirely on the assumption of arterial compressibility. If calcium turns the artery into a PVC pipe, the test breaks. So a high ABI of 1.40 or above is actually a giant red flag. It is not a gold star for excellent blood flow. It means the test is entirely invalid due to medial calcification.
If a primary care clinician doesn't grasp that nuance, they might send a diabetic patient home thinking they have superhero blood pressure in their legs, when in reality their limb is starving and in extreme danger.
Precisely, which is why vascular specialists had to adapt. When they see that incompressible 1.40 ABI, they immediately pivot to a different diagnostic tool, the toe brachial index.
Measuring the toe.
Right. They place a tiny specialized blood pressure cuff on the smaller digital arteries of the big toe. For reasons that vascular biology is still working to fully map out, those tiny toe arteries are highly resistant to that severe Munkeberg's calcification. They usually remain compressible, giving us an accurate, unmasked reading of the starvation happening downstream.
The fact that our gold standard test has these massive blind spots makes a lot more sense when you realize how incredibly fractured the history of this disease is. I mean, we didn't figure out the mechanics of PAD in some high-tech modern lab.
Yeah.
We actually started by looking at horses.
Yeah, the historical timeline of vascular medicine is remarkable, mostly because the primary symptom was named and documented over a century before anyone possessed the technology to actually test for the cause.
We have to talk about Jacques Boulet. The year is 1831. He's a prominent French veterinarian, and he starts observing that certain horses develop this strange, severe limping gait after they've been exercised. But the limp completely vanishes when they are allowed to rest.
Sound familiar?
Exactly. He actually conducts post-mortem dissections and connects this predictable limping to arterial obstructions in the horse's legs. He uses the Latin word claudicare, which literally means to limp. And that is exactly where the medical term intermittent claudication comes from.
But for decades, this phenomenon remained entirely sequestered within veterinary literature.
Because doctors weren't reading vet journals.
Right. It wasn't until 1858 that a famous French neurologist, Jean-Martin Charcot, achieved a massive medical breakthrough. Charcot read Boulet's veterinary work and realized, wait a minute, my human patients are describing this exact same walk and rest pattern of pain.
Wow.
It was revolutionary for a neurologist to cross over into vascular pathology, but Charcot successfully bridged the gap, connecting the limping horses to obstructed arteries in human legs.
But even with Charcot's brilliant insight, doctors were still just diagnosing it by asking the patient if their legs hurt. Fast forward almost a century to 1950. An American cardiologist named Travis Windsor formally invents the ABI. He figures out the baseline ankle-to-arm math, but practically nobody uses it.
Because the mathematical theory was sound, but the field lacked the necessary hardware. You couldn't just use a stethoscope to reliably hear blood flow at the ankle, especially in a diseased artery.
Right. You can't hear a trickle.
Exactly.
Fine.
It wasn't until portable Doppler ultrasound devices became widely available in vascular labs in the late 1960s and 70s that the ABI became the clinical workhorse. The Doppler probe uses bounced sound waves to detect the velocity of red blood cells, which allow doctors to quickly and objectively hear the pulse at the ankle and capture an accurate pressure reading.
And once the diagnostics finally caught up, the treatment side of the disease had its own incredibly rebellious origin story. Let's look at 1964. A radiologist named Charles Daughter has a patient, an 82-year-old woman named Laura Shaw. She has a gangrenous left foot from severe PAD. The surgical establishment tells her she needs an immediate amputation. She absolutely refuses to let them cut off her leg.
The surgical consensus at the time was that amputation or massive open bypass were the only options. But Goddard, being a radiologist who specialized in imaging blood vessels, hypothesized a radically different, minimally invasive approach. He took a rigid Teflon catheter, essentially a specialized wire tube, threaded it directly inside her diseased leg artery, and mechanically dilated the narrowed plaque by forcing progressively larger catheters through the blockage.
He just mechanically brute forced the pipe open from the inside out, completely ignoring the surgeons.
Exactly. It was the first transluminal angioplasty in the history of medicine.
Hmm.
And it worked. Laura Shaw's circulation returned, her gangrenous foot healed, and she walked on that leg for the rest of her life.
That is incredible.
Now, the American surgical establishment was incredibly hostile to this. They thought Dotter was reckless. But the technique found an audience in Europe. In the 1970s, a physician named Andreas Grinzig refined Dotter's crude Teflon technique by adding an inflatable balloon to the tip of the catheter.
Oh, the balloon angioplasty.
Yes, you navigate to the blockage, inflate the balloon to high pressure, and simply crush the plaque outward against the arterial walls.
Here's where it gets really interesting. That revolutionary balloon angioplasty technique was pioneered entirely for leg arteries. But by 1977, they adapted it for the coronary arteries and the heart. So the entire modern, multi-billion-dollar field of interventional cardiology, the tools we use to treat millions of heart attacks today with balloons and stents, literally traces its ancestral roots back to a French veterinarian watching limping horses and a rebellious radiologist attempting to save one 82-year-old woman's foot.
It's a profound reminder of how medical innovation often moves laterally rather than linearly. And we should also quickly acknowledge Jean Cunlin, who in 1948 in Paris pioneered the other side of treatment. He took a piece of a patient's own healthy saphenous vein from their leg and surgically sewed it above and below a blockage, performing the first successful vascular bypass.
Right. So today, endovascular angioplasty and open surgical bypass remain the two primary mechanical pillars for treating PA.
They do.
We have an arsenal of incredible high-tech tools to fix the plumbing. We have high-pressure balloons, medicated metal stents, and intricate surgical bypasses. But our sources reveal a fierce debate today. Just because we can operate and push metal into a leg doesn't mean we always should.
This raises an important question, and it is the central clinical debate in PAD management right now. It really comes down to the sequencing of care. For decades, if you presented with moderate claudication, the decision to operate or just prescribe walking depended heavily on the specific bias of the specialist you happened to see.
Which brings us to the CLEVER trial in 2012. CLEVER stands for claudication, exercise versus endoluminal revascularization. They took patients suffering from claudication and put these two philosophies head-to-head.
Right.
One group gets a high-tech metal stent deployed to permanently prop their artery open. The other group gets put on a supervised treadmill exercise program. No surgery, just forced walking until they hit ischemic pain, resting and walking again multiple times a week. And the results at 6 months. The treadmill group actually demonstrated better sustained improvements in walking distance and quality of life than the group that got the surgical stent.
Pretty amazing.
I want to challenge this because the engineering mindset would tell you to just stent the artery. Prop the pipe open mechanically, problem solved. I thought fixing a blocked pipe required a plumber. How can supervised walking, literally demanding more from a starting limb, mechanically outperform a high-tech stent?
Well, it highlights the brilliance of human angiogenesis, which is the creation of new blood vessels. When you force a patient to walk on a treadmill, specifically to the point of ischemic pain, you are intentionally triggering a state of mild, controlled starvation and cellular stress in the muscle.
Okay.
That stressed tissue responds by releasing a cascade of specific growth factors, most notably VEGF, or vascular endothelial growth factor.
So the starvation itself is the signal.
Exactly. Those growth factors instruct the body's vascular system to build new arterial networks. Over months of supervised repetitive exercise, the body grows a robust network of tiny, brand-new collateral vessels, those natural biological bypass channels we mentioned earlier, that completely detour around the main atherosclerotic blockage.
Wow. You are essentially demanding that the body replumbs itself.
Right. A stent just forces open one lane of the existing highway, which can eventually clog again. Exercise builds an entire redundant network of side streets.
That is deeply fascinating. So for early-stage claudication, the current medical consensus is hit the treadmill, quit smoking, aggressively manage your diabetes. But what about the other end of the spectrum? The severe CLTI patients with ulcers who are facing amputation.
That exact dilemma was addressed by the BEST CLI trial, published in 2023. It was one of the most anticipated vascular trials in a generation.
Because people didn't know whether to stent or bypass.
Yes. For severe limb-threatening disease, the field had drifted heavily toward attempting catheter-based endovascular procedures first, simply because they are less invasive than cutting the leg open.
That makes sense.
But Best CLI showed that if a patient have a good quality piece of their own vein available to use, open surgical bypass actually results in fewer major amputations and fewer repeat procedures than the catheter approach.
Because the body's own vein is biologically superior for long-term blood flow compared to synthetic materials or stented native arteries. It proved that sometimes the older, more invasive surgery is undeniably the better long-term fix. But there's a darker side to that endovascular drift you mentioned. Our sources dive into a massive controversy regarding a specific catheter procedure called atherectomy.
Yes, atherectomy is an advanced endovascular technique where instead of just crushing the plaque outward with a balloon, a specialized spinning or laser device is introduced into the artery to actually shave, cut, or vaporize the plaque directly out of the vessel wall.
Wait, shaving and vaporizing plaque out of a delicate artery? Isn't there a massive danger of that pulverized cellular debris just flowing downstream with the blood and causing a catastrophic stroke or blockage in the tiny vessels of the foot?
That is precisely the primary engineering risk of the device, which is why operators deploy tiny distal embolic protection filters, basically microscopic umbrellas, downstream of the cutting tool to catch the debris, or they use continuous mechanical suction to vacuum out the vaporized plaque.
Okay, so the engineering accounts for the debris, but what is the actual controversy?
The controversy centers on healthcare economics and reimbursement structures in the United States. Outpatient, office-based vascular labs can bill Medicare separately, and quite lucratively, for utilizing these specialized atherectomy devices.
Oh, I see where this is going.
Right. Investigative reporting over the last decade identified certain physicians who were performing hundreds, sometimes thousands, of these high reimbursement atherectomy procedures a year, rates that far exceeded what the actual objective disease prevalence in their local population could possibly justify.
So it's a stark case study in how financial incentives can potentially distort clinical decision-making, leading to the aggressive overtreatment of mild cases that might have been better served by a treadmill and some medication. Now, to be clear to you listening, our goal isn't to take a political stance on healthcare economics. We're just reporting what the sources highlight regarding the billing structures.
Absolutely. It just underscores the necessity of strict evidence-based guidelines. And speaking of prevalence, we also need to address the demographics of who is actually suffering from P8, because the clinical profile is shifting rapidly.
Right, there is this persistent, almost cinematic stereotype that PAID only happens to 80-year-old men who have chain smoked their entire adult lives.
Smoking remains a massive, highly destructive risk factor, yes. But the exploding global diabetes epidemic is now a primary driver of complex calcified P8. Furthermore, the data clearly shows that women are frequently underdiagnosed.
Why is that?
They are statistically much more likely to present with the atypical leg symptoms, the subtle heaviness or weakness, rather than the classic textbook limp, so the diagnosis is often completely missed in primary care settings until the disease is dangerously advanced.
And the U.S. population data highlights stark disparities as well. Research consistently demonstrates that Black Americans have a significantly higher prevalence of PAD than white Americans across nearly every age cohort.
Yes, it's a major issue.
And crucially, that elevated risk remains true even when researchers statistically adjust for traditional risk factors like smoking or hypertension, pointing to deeply complex intersections of genetics, systemic health, and healthcare access.
And if we connect this to the bigger picture, we have to talk about the Capri trial, because this is arguably the most sobering and vital takeaway from all of this clinical data. We've spent this entire time talking about leg arteries and walking pain. But PAID is absolutely not a leg problem.
Right, it's a systemic alarm.
The Capri trial in 1996 followed nearly 19,000 patients, and the data analysis revealed a terrifying truth. Patients who were diagnosed with symptomatic PA had subsequent rates of heart attack, stroke, and cardiovascular death that matched, and in some subgroups even exceeded, patients who had already survived a previous confirmed heart attack.
Wow. Because atherosclerosis is a panvascular disease. It doesn't just pick one single artery in your calf to attack. If you have a hardened, calcified plaque choking off the blood supply to your leg, the statistical probability is incredibly high that you also have plaque quietly choking off the coronary arteries to your heart and the carotid arteries to your brain.
Exactly. The systemic total body nature of atherosclerosis is why the 5-year mortality rate following a symptomatic PA diagnosis has historically been comparable to several common, highly aggressive cancers.
That is staggering.
And the tragic reality is that almost none of those patients ultimately die from their leg disease. They die from the sudden downstream heart attack or stroke that their aching leg was desperately trying to warn them about.
So what does this all mean? Let's distill this down for you, the listener, because this is intensely actionable information. First, PAE is a stealth disease defined by a measurable number, the ABI, not just by the presence of a limp. Second, remember the PVC pipe. A heavily elevated ABI above 1.40 isn't a gold star for health. It's a structural warning that your arteries might be calcified and stiff from diabetes or kidney disease, requiring a toe pressure test.
Very true.
Third, and most crucially, leg claudication is your body's early warning system. It is a blaring systemic alarm regarding your overarching cardiovascular health.
And we must emphasize that every single major driver of this disease, smoking, uncontrolled blood sugar, high blood pressure, and a sedentary lifestyle, is highly modifiable. You can change the trajectory.
Understanding this isn't just about absorbing interesting vascular history. It is a vital, potentially life-saving piece of health literacy. Knowing that a simple, non-invasive 10-minute blood pressure check at the ankle could reveal hidden systemic plaque might prompt you, or a loved one, to request an ABI screening from a doctor before a catastrophic heart attack ever happens. The knowledge you have right now literally has the power to change clinical outcomes.
It grants you the ultimate medical luxury, the chance to intervene while you still have time.
We started this deep dive exploring the mechanics of a starving limb, and we saw how a treadmill could physically outperform a metal stent by forcing the body to grow its own microscopic bypass channels. But I want to leave you with this final provocative thought. If we know that supervised walking triggers the release of very specific growth factors like VEGF that tell the human body to build brand new arteries, what if the future of treating cardiovascular disease isn't mechanical or surgical at all, but molecular? What if we could isolate that exact biological signaling cascade, the exact molecular instructions triggered by an aching calf, and deliver the body's innate ability to completely replumb itself in a single pill?
Now that is a truly fascinating frontier.
Something to think about the next time you feel the burn taking the stairs.